So next time you're on a plane with 200 other people, look around because 4 of them are going to have
Oh,
psychosis.
geez, geez.
Welcome to the Evidence-Based Urgentology podcast from EB Medicine, where urgent care meets evidence. I'm Joe Toscano, Senior Research Editor for Emergency Medicine Practice and a member of the Evidence-Based Urgent Care Editorial Board.
Hi there, and I'm Tracy Davidoff. I'm Editor-in-Chief of Evidence-Based Urgent Care, and we're practicing urgent care physicians with years of experience, probably too many years of experience, on the front lines. And for us, diagnosis is detective work, and the clues are in the history, the exam, and of course, the evidence. That thrill of solving the patient's puzzle is really what keeps us coming back.
Each month, we unpack the latest issue of Evidence-Based Urgent Care, tackling common chief complaints from presentation through diagnosis to disposition. We highlight the best evidence, the key takeaways, and the clinical pearls.
And by the end of every episode, you'll have sharper skills, deeper knowledge, and more sound strategies that you can use on your very next shift. So let's dive in. The evidence starts now. And remember, you can always find more at www.ebmedicine.net. Hi all, and welcome to this episode of the Urgentology podcast. Just a couple of housekeeping things. We want to tell you that evidence-based urgent care is now being continuously updated. That's right. Since evidence-based urgent care is in its fourth year, hard to believe we're in our fourth year of publication, the topics are being continuously reviewed and updated so that the CME remains current. That way you'll never run out of CME. It'll always be current anyway, and certainly applicable. And after all, we try to be really up to date with our evidence-based stuff here. So a full year subscription will provide an urgent care clinician with up to 48 hours of CME. That's a lot of CME.
That is a lot.
Yes,
Wow.
it is. So what are we going to talk about today, Joe?
Well, hey, congrats on 4 years. Wow, it's big. That went by really fast.
Yeah.
Well, hey, we're going to discuss the October 2025 issue, which is on the diagnosis and management of international travel-related illnesses in urgent care patients. Our author is Dr. Mark K. Huntington, who's a professor of family medicine at University of South Dakota.
And the peer reviewers are Hector Cabrera and one of my very close friends, Jackie Verheilig, who's an infectious disease and travel medicine expert.
That's awesome.
Yep.
Hey, we're going to try another little different format where this was sort of a very interesting piece, I thought, and something that would take us a very long time to go through and actually review. So Tracy and I decided just to kind of pick a few points that we thought were really important and one point that we learned something new. And so that's what we're going to do for this month.
Yeah, that's true. This issue is really a bear. I mean, it's like, 60 pages long or something like that, because there's just so many diseases that one can get traveling the world. Travel used to just be for the rich people, but now everybody's traveling. You can travel on a little budget. You can travel on a big budget. And people are being exposed to stuff all over the place. And, even if you live in Montana or if you live where I do, where I see people from all over the world, you're going to see people who are coming back with travel-related concerns. And the one thing that he also mentioned in the issue is that it's not just people who are traveling. I mean, think about immigrants too. Those who are new to the country and maybe have not had all their vaccinations or came from someplace really rural in their country, or even maybe they traveled back to their country for a trip or something or to visit family and they don't happen to mention that. So not just the person on vacation, you think about a lot of people that could potentially be exposed to such things.
Yep. Anybody who's gone out of the country.
Yep.
So I'll start. I think an important point is that making a diagnosis, and it can be complicated, but kind of have a system of doing it. It's really the intersection of knowing the geography of disease, some syndromic patterns and incubation period. And if you kind of think about all of those things, that's going to lead you to a diagnosis. In terms of the syndromic patterns, there's kind of fever predominant. There's also a category to think about where fever has been present for over a week or so and malaria has already been ruled out. Respiratory illnesses, GI type stuff, which can be viral, bacterial, parasitic. And you can have microparasites or macroparasites where you can actually see these worms like a foot long or longer. Oof.
Ew.
And then, the skin is important for a lot of these things too. You can either have a primary infection of the skin, stuff as mundane as scabies, bed bugs, Yersinia, to the more exotic stuff that includes a variety of worms, or even got to keep stuff like leprosy in mind sometimes. But then there's rashes that accompany viral diseases or rickettsial diseases. So the skin can actually be pretty important. And it's all covered up unless we ask the patient to disrobe. So asking whether they have a rash and then actually examining them is important. Jaundice is also a particular finding that correlates with a variety of ailments, including hepatitis A, B, C, et cetera, based on what the individual's been doing while they're traveling, but also liver abscess, which has a variety of different causes, or biliary obstruction from the usual stuff like stones, but also parasitic infection where the worms get in the bile duct and cause obstructive jaundice. Wow, crazy stuff.
Ick.
Yeah, and in terms of the geography of disease, basically knowing what's endemic in the areas where the person traveled to. And all of this really speaks to the primacy of the H&P. There's some tests, who knows, we may talk about a couple of tests here, but really the history and exam are going to guide most of our diagnostic process. And it's kind of interesting. Most of these infections are limited to the individual when they get infected abroad, but some of them are contagious, some of the respiratory diseases and diarrheal things and a few others. So that might affect your incubation period calculations. And think about Zika, which can be excreted as a viable organism in the semen for up to 9 months after infection, even in somebody who's been asymptomatic. So I don't know how you'd figure out something like that real time, but it's in the background of these infections here. Kind of amazing stuff.
Yep. Yeah, one of the things, I probably should have started with this is the most important thing is getting in that history and finding out that the patient did travel. Because if you don't
Mhm.
ask, you won't know. I had a gentleman a couple months ago who came in with diarrhea. It had been for a week. I asked all the questions about blood in the stool. Is there mucus in the stool? How many times a day? Vomiting. And the last thing I asked, which probably should have been the first thing I asked, is, have you traveled anywhere? And his response was, oh, well, now that you mention it. So he probably wouldn't have given that up if I hadn't have specifically asked. And he turned out to
Mhm.
have cryptosporidium. So he was somewhere in South America where he had gone that he ended up with that. So you got to ask. If you don't ask, you won't know. I mean, it's really obvious if somebody comes in with an accent or they have a suitcase with them or,
Mhm.
something that makes you think that they've traveled, or if they have the concern that this is something I picked up abroad. But I always ask, all my diarrhea and my rashes, and not necessarily respiratory, but usually diarrhea, rash, and fever, have you traveled anywhere? And a lot of times they'll kind of look at you kind of funny. Actually, now for COVID, I always ask that too, because cruise ships are a really good place to pick up COVID. But yeah, if you're suspecting some sort of an infectious disease, it's always a really good idea to ask about travel, because if you didn't ask, you won't know.
You will not know. It's a couple of years ago during flu and COVID kind of winter, and I had a patient like that. And you kind of fall out of the habit once you see your 100th flu patient, your 100th COVID patient. And it was somebody who had kind of fever and systemic symptoms. And as we were kind of wrapping up, I said, well, your tests are negative, but it's probably some virus. And he goes, well, how much longer is this gonna last? Because I still haven't unpacked my bag from my trip to Brazil. I'm like, oh yeah, we probably should have led with that. So anyway, it's important to ask. Absolutely. So when you're dealing with fever in a returning traveler, really the number one thing you have to rule out is malaria if they went to an endemic area. And there's a range of severity of presentations, but for most, it's a pretty debilitating prostrating type illness. Studies have shown the average delay in diagnosis from first medical contact is about 7 days. And some of the tests have a long turnaround time, but that delay is predominantly because of a failure to consider the diagnosis.
Yeah.
Yeah, it's important to consider differences in geography. There are different forms of malaria. Falciparum is the one that's deadly and can kill you in 24 hours. So most of the time we're going to be treating empirically while we're waiting for our test results to come back. But if you have somebody who's really sick, those people need to get sent onto the ED. It's important to know what your options for testing for malaria are. The classic test is this thick and thin smear, but PCR tests are available as well. We actually had a returning traveler who had been to South America, and we sent the tests from our clinic. And thick and thin smear was a 2-day turnaround, and the PCR was 4, because I think that was even sent out
Wow.
to another lab. It wasn't really locally done. So it's important to know those things, how you're going to test, and then, what the turnaround time is. The issue emphasized the fact that a CBC does not diagnose malaria. And I think the confusion may come because it's the same stain. I think you can use a couple of different stains to diagnose malaria on the thick and thin smear, but that Gamesa stain that is kind of the best for malaria is also what's used for a CBC smear, but that's like less than a thin smear. So to get your yield on parasites and get the best sensitivity, you got to do a thick and a thin smear. A CBC just will not demonstrate it.
This might be worth a phone call to call in that lab and saying, hey, this is what I'm looking
Yeah.
for. Because I remember when I was still doing ER, I had one that I was suspicious of, and I sent it to the lab, and I specifically ordered, need you to do a manual exam of this because I'm thinking about malaria. And it came back with an automated thing. And I'm like, that's not helpful. So I had to
Yeah.
call them back and say, I'm looking for malaria. And of course, the answer was, wow, we haven't done that in a really long time. I'm not sure we remember how. So yeah, you might want to give your lab a heads up before you send something like that.
Yep. Yep. Nope, for sure. Because all the tests are going to take a little while. I mean, in the ED, we can get a thick and thin smear back in a couple of hours. But most of the time in urgent care, you're going to be treating these patients empirically. If you suspect it, you can go ahead and start a course of treatment and wait for your test results. It's really a diagnosis you don't want to miss. Now, none of us are malaria experts, or I don't know, maybe some people are, but I'm certainly not. And the kind of cool thing is that the CDC has a treatment line available for consults 24 hours a day. There's a daytime number and an on-call nights, weekends, holiday number. And basically, you should be prepared to talk to them about the patient's travel history because it can influence resistance patterns and what your regimen is going to be. And basically, it can help out a lot. So if you're suspecting malaria, which you should as your number one diagnosis, if it's a fever predominant illness, send your tests, but go ahead and call the CDC malaria treatment line and start some treatment while you're waiting for your test results.
Yep. All right. So one of the other things we should talk about too, the opposite end of that is just because the patient is a returning traveler doesn't mean they have something exotic.
Mhm.
Common things occur commonly, and travelers are subjected to the same illnesses as non-travelers, like colds and flus. I mean, anybody who's ever traveled on an airplane knows that the guy sitting next to you has a cold. There's a pretty safe bet you're going to have it by the time you get home. Contact dermatitis, people are wearing new clothing, they're trying new things, they're doing different things. Maybe viral gastroenteritis, that's also pretty common. They're being exposed to a lot of other travelers that they're traveling with. Things like that are common. Bed bugs, you mentioned that earlier. People are staying in hotels or Airbnbs or hostels or things like that. The bed bugs are the same here as they are there. So entirely possible that you can get something like that. So definitely think about those exotic things, but don't get hung up on that because common things do occur commonly. COVID, we see with travel all the time. Flu. And
Mhm.
remember, flu is different in different parts of the world. Remember, the Southern Hemisphere
Mhm.
has flu the opposite that we do. So
Mhm.
just because it's the middle of July doesn't mean the person doesn't have flu, because if they went to Australia, they just might. So things to think about when you're thinking about travelers.
One of the things that I thought was interesting too is the viral illnesses that people can get. A lot of them have no specific treatment, but it's still important to diagnose them or have some idea what you might be dealing with and then maybe consider sending off some tests. There's a great chart in the issue that contrasts the arboviruses, which are dengue, Zika, and chikungunya, which one has more of a headache, what type of rash, myalgias, arthralgias, and then pruritus, which is kind of really more common with Zika, the Zika rash. And it's important to know that because Zika can be associated with thrombocytopenia. There's a hemorrhagic form of dengue. And if it's not presenting that way, you still want to keep it in mind and be able to give anticipatory guidance to the patient, specifically if they start to get more ill. You also want to avoid NSAIDs if you suspect it's dengue because of that hemorrhagic issue and maybe even Zika. And then I alluded to it earlier, but if you think a patient, particularly a male patient, might have Zika, female patients need to be careful about getting pregnant because the high rate of in utero defects with that virus, certainly while they're ill with it, but how long that extends, it's kind of difficult to know. But a male with Zika is going to want to use some type of barrier protection for many months afterwards because the virus can be transmitted in the semen. I think the record is 281 days, which is about 9 months. So yeah, it's important not just to say, oh, it's just a virus, you're going to be fine and live your life the same as you did before. If you think somebody had Zika, those things are important for them to keep in mind, and we got to counsel patients accordingly.
Yeah, so that's important. It's supportive care. So, like, who cares which viruses they have? But because the outcomes and the complications can be so different, that makes it important to know which one they have. And the overlap of the areas where these diseases occur are so much that you can't pin it down by geography, which virus is occurring where, because there's a significant amount of overlap for them. So fever, rash, myalgias, and travel to endemic areas, that's where you really got to start thinking about that. And I tested somebody for, I think it was dengue a couple months ago. They had been to was it the Bahamas, Dominican Republic, somewhere in the Caribbean. And she was really nervous because she was trying to get pregnant. And she had a fever and a rash that really didn't look like a rash. It looked more like, I rubbed my skin against something, but she was pretty nervous about it. So we sent off the dengue. It took about a week to get it back, but it was subsequently negative.
She's trying to get pregnant. She'd probably rather have dengue than Zika, I guess, huh?
Yeah. Or maybe it was Zika. No, it was dengue. It was dengue. Yeah. Yeah. All right. What else are we going to talk about? Oh, diarrhea. Oh my goodness. Diarrhea.
Mm.
Traveler's diarrhea. That's a real common one. You see that a whole heck of a lot in returning travelers. And most of the time it's going to be a bacterial. E. coli is the one, but it's not an evil E. coli. It's a self-limited E. coli. And it usually pretty much
Mhm.
resolves on its own and doesn't really need any antibacterial or antibiotic treatment to support our efforts in antibiotic stewardship. You shouldn't just jump right to the antibiotic because it'll usually clear itself in 24 to 48 hours. One of my standard lines to patients is be like Elsa, just let it go. Your body's trying to get rid of something it doesn't want, just let it out of there. And then it'll usually get better on its own. But if you do have somebody that's got really severe symptoms like bloody diarrhea, or they're significantly dehydrated, or they have fever more than a day or two, or they're just not clearing up in a week or so, then you might want to start thinking about doing something else. I mean, obviously, if they're clearly unstable, they're dehydrated, they need IV
Mhm.
fluids that you can't provide, or you don't feel comfortable giving more than a liter or two, or if you want to know what their electrolyte status is, or if they have bleeding, or if you have any concerns about acute abdomen or anything like that, that's the person you're going to be sending off to the emergency department. But, by and large, most of the people you see are going to have mild to moderate symptoms and they're not going to need any treatment. One of the important points here is that if you do decide that they need treatment, it might behoove you to try and get some stool studies to see
Mhm.
exactly what you're treating, because different types of the diarrhea require different antibiotics. If it's someone that, it's the first couple days and they have some severe symptoms and you're pretty sure it's traveler's diarrhea, you can go ahead and kind of empirically treat them. And for years, I was treating people with Cipro, but Cipro now is a no-no because there's a ton of resistance to the Cipro, especially in Asia. So if you have
Mhm.
a traveler that's coming back from Asia and they have traveler's diarrhea, there's probably an 80% chance that Cipro isn't going to work. So now the recommended treatment is gasp, azithromycin. So it's recommended that you do that. You can either do a single dose or you can do like a 3-day dose. As everyone knows that's ever listened to this podcast, not my favorite drug, because the bacteria are really smart. They know how to get around it. So they does
Mhm.
develop resistance. And I'm pretty sure maybe the next time we do this podcast talking about traveler's diarrhea, that it'll be too resistant and we'll be asking for another antibiotic. But now that's first line. And I'm traveling and I threw a Z-Pack in my bag just in case. But yeah, that's now the recommended one. So skip the Cipro and go to the Zithromax. And again, if people are not getting better or they failed treatment or you're concerned about something more serious, then it's time to send off those stool studies, usually some sort of multiplex PCR type testing. But again, know where the patient traveled and know what you can potentially expect to get on your result. And you can treat them, but send the test and then treat them if you most possibly can.
Mhm. One of the other important points on this subject is that preventative measures that people take, we want people to take preventive measures, but it does not eliminate the risk.
Right.
Nothing does in that regard. So you still have to be suspicious based on the syndrome and the travel history and the incubation period, geography, all that kind of stuff. Again, if you're counseling people on the front end, you want them to think about prevention because it does reduce the risk. It just doesn't eliminate it. So you want to counsel patients about appropriate vaccinations for intended travel and for people to get them in time before they go so that they have a chance to develop the immunity, protective clothing and bed netting and other mosquito and insect precautions, and then pre-exposure prophylaxis for malaria to make sure for those forms that are needed that they started adequately before and continue it after they come back. Sometimes people start late or just think when they come back they don't have to take it anymore. So all of those things are important for appropriate prevention, but even then, you have to have a high degree of suspicion. If a traveler comes back with some illness, you kind of disregard the prevention and go through your usual diagnostic process with them.
Yeah, and that's really important for malaria because a lot of people will think that they can't get malaria if they've taken the prophylaxis, and that's completely untrue. It's not 100% in preventing it. And if you don't feel comfortable giving any pre travel advice, there are plenty of travel clinics around. Usually, your local health department is a good place to go. Yellow fever vaccine, really kind of a hard one to find because there's a lot of hoops to jump through to be able to dispense that. And it's also very expensive and not asked for very often. So, a lot of places don't want to keep it on stock. So you can't usually go to your local CVS or Walgreens vaccination clinic and get the yellow fever. You got to go get it somewhere special, either a travel clinic or your local health department. And a lot of people don't realize that they should do that sort of a consultation before they
Hmm.
travel. There's really good information online with the CDC. You can just plug in the country you're going to and it'll tell you what's recommended, which is a good start. But any concern, recommend that the people go get a travel medicine consultation.
For sure.
So one of the other things, that we always say, if you're really concerned about a patient being super sick, please don't mess around doing labs and maybe giving some advice and not appreciating that the patient's really sick. If you have any sort of abnormal vital signs or you're concerned they're not going to follow up, you don't feel you have the capability of working up malaria as an outpatient, please err on the side of caution and send that patient to the emergency department, especially if they're unstable in any way. Vital signs, remember, we always mention vital signs, so important. If there's something abnormal there, explain it, treat it, refer it. because
Hmm.
that's the one thing that's going to clue you into how sick a patient really is. Diarrhea, if they have acute abdomen or they seem like they have any dehydration, respiratory stuff, if they're, not satting well, or they look like they're tachypnic, or you're concerned about their status at home, send them forward. Or if you don't have the capability of figuring out what's wrong with them, don't rely on outpatient because they can get lost to follow up. If it's something that you think is really important, make sure
Hmm.
that that follow up is taken care of either emergently or semi-emergently. I know if I ordered a malaria smear or something like that and I expected my next coworker the next day to follow up on that, I don't think they'd be very happy about it.
Yeah.
But communicate, I guess.
Hmm. Hmm. Hey, for my new thing learned, I had heard about that anti-malarial mefloquine kind of being associated with depression and suicidality and all that. And so you have to be careful to whom you prescribe it. But just psych issues in general being triggered by travel, I had no idea.
Yeah.
The issue noted an incidence of 11% overall, though they said only a small percentage of people seek care. And just upwards of 2% actually experience psychosis.
Hmm.
So next time you're on a plane with 200 other people, look around because 4 of them are gonna have
Oh,
psychosis.
geez. Jeez.
Oh my goodness, I'm gonna be looking at everybody coming on board now. And the issues that can occur with travel or time zone changes and jet lag, which can lead to poor sleep, and that can stress people, actually, their health in general, but particularly their mental health. It can lead to changes in medication dosage and timing. There's stress from cultural changes, and alcohol use can be different when you travel, as well as the use of both prescription and illicit drugs or the abuse of those. Drug use itself was reported to be a trigger in about 33% of those who sought care for psychiatric issues. And it's often a trigger for those who experience significant psychosis while traveling. So, something to keep in mind. I guess that might more often occur while they're traveling versus after they come back, but it could spill over. So, it's important to keep that in mind.
Yeah, that's crazy. I mean, I could see the whole anxiety thing. A lot of people get very anxious when they travel. That's certainly the case. But I guess a lot of people get depressed after they've been on a long trip. Maybe they're sorry it's over, or maybe they saw things that they didn't expect or something like that. Not quite sure how that works. But one of the other comments that was in the article is a lot of people in their late teens and 20s will go do a post school trip or a gap year or something like that. And that happens to be when most schizophrenics will
Mhm.
start presenting. So maybe it's just coincidental that it happened to be when they were traveling. But yeah, something to think about. Yeah, what I learned from this issue that I was surprised I didn't know is that malaria can present years afterwards, like 10,
Mhm.
15 years later. You can suddenly develop malaria. I guess it lays dormant in your blood system for a while. So if you got somebody with a fever without a source, with relapsing and that sort of thing, and you can't figure it out, ask them, hey, did you go to Africa 15 years ago? They'll probably look at you like you're crazy. But yeah, that's definitely something to think about if you're trying to figure out what a fever is and you don't have a good source for it.
Yeah.
So there's lots of good stuff in the issue. Again, we said it's really, really long and there's lots of tables and charts, but there's lots of good stuff to look at in there. So if you have the time, skim through it. A lot of the stuff can be more used for reference, but there is definitely a lot of useful information in there. The malaria hotline, knowing about that is a good thing.
Mhm.
Just the various different parasites that can occur. That's good to be able to look at that. So a lot of good, useful information in the issue. So take a look at that.
Yeah. And though it's impossible to memorize, the issue does kind of boil it down and systematize it in a way that this would be good just to keep as a resource. When you have a traveler who's ill, you can kind of look through here and again, look at that intersection between where they traveled, what their symptoms are in the incubation period, and kind of whittle it down pretty well because it's impossible to commit all this stuff to memory, I
Oh,
think.
yeah.
So,
Yeah.
yeah, it's a good resource. What do we have for next month?
Next month is what is next month? I don't even remember what next month is. I don't remember. So it's going to be a
Yeah,
surprise.
that sounds good. I like
That's
surprise.
because I don't remember what it is. Is that horrible? Yeah.
Yeah.
But yeah, we got a bunch of stuff coming down the pike. We've got testing, talking about different testing and sensitivity and
Mhm.
specificities, and which test to order for what, and that sort of thing. We got that coming down. We've got hypertension. That's going to be, I think, December, which will be really good. Actually,
Great.
I think testing is next month. And then hypertension for December. We have some marine injuries coming up. Eventually, we'll have some sinusitis coming up. Would you believe we don't have an article on sinusitis? Is that crazy? Probably the number one
Way.
thing that we see in urgent care, and we don't have an issue on that. So we're working on that too.
Great.
All right. Well, thanks for tuning in, everybody. We appreciate
Yeah.
you. And we hope you learned something today on your evidence based urgent care returning travelers issue.
Take care, everyone.
All right. Take
Thank you.
care. Bye bye.
All right. Bye bye.
I want to thank everybody for listening to this month's evidence-based urgentology podcast. Just a reminder that subscribers can go to evmedicine.net and read the full issue if you want more information, if you haven't already.
And if you're not a subscriber, head to the site, that's evmedicine.net, to check out what they have. If you subscribe, you'll get access to the article, as well as future articles and the whole archive of all past issues.
Look forward to seeing you there.